Hi, everyone. I'm Joyce Oleszek from Children's Hospital, Colorado. Wow, thank you so much, Sarah Todd, for sharing your amazingly inspiring story. You brought a big smile to my face over and over. You're a tough act to follow. I want to start by thanking Drs. Pardo and Sadowski, as well as Janet Dean, for asking me to be part of this incredible AFM symposium. I'm honored to be here today. I have no disclosures to report. Over the course of the last few weeks, we've heard a great deal about the acute presentations and management of children with AFM. Today, I'm going to discuss the long-term management from both medical and functional perspectives. I'll end by sharing the journeys of two of my patients. Listed here are some of the possible chronic medical conditions seen in children with AFM. When we think about these long-term conditions, we need to remember the fact that no two children with AFM are alike. They have such varied neurologic presentations, from only one limb affected to quadriplegia or all four limbs affected. So is the same for medical systems involved. Some children present with cranial nerve, bowel, or bladder dysfunction, while others have minimal to no involvement of these systems. Some patients develop respiratory failure to the point of requiring a tracheostomy, whereas other children have only mild upper respiratory symptoms. Dr. Riggs gave an insightful presentation on respiratory dysfunction a few weeks ago, and we'll be hearing more about respiratory health from Dr. Malacosta in a little bit. I'll discuss the other conditions listed here in the next few slides. In AFM, bladder and bowel dysfunction are typically of the lower motor neuron type, resulting in incontinence. The flaccid bladder increases risks of urinary tract infections and renal stones, and intermittent catheterization may be necessary. The lower motor neuron bowel lacks spinal cord mediated peristalsis, and a daily bowel program is often necessary to achieve social continence. Several studies report the incidence of bowel, bladder, and cranial nerve dysfunction in the acute phase. However, there is minimal data regarding long-term medical complications in children with AFM. Dr. Beauvais' study provides the most data in this area, with information on persistent deficits in 167 children with AFM at a mean duration of 2.4 years after onset, as recalled by their caregivers in a closed Facebook group survey. In Dr. Beauvais' study, caregivers reported incontinence in 29% of children, which indicates that this can be a significant problem. It is imperative that these children receive routine urologic care for monitoring and surveillance protocols. Studies have shown that approximately 30% of children with AFM have cranial nerve dysfunction at onset. This can consist of oculomotor and facial weakness due to cranial nerve 6 and 7 dysfunction, and more commonly, dysarthria or dysphagia due to cranial nerve 9 and 10 function. In Colorado, we found that cranial nerve weakness is more likely to improve than limb weakness. In Dr. Beauvais' study again, 16% of caregivers continued to report problems with dysphagia. It is important to continually monitor swallowing and need for supplemental or alternative means of nutrition. Work with speech-language pathologists and feeding therapy is essential to help support the recovery of this bulbar weakness. We will hear about the management of low bone mineral density from Drs. Jane and Sadowski later this afternoon. But I felt it important to mention here, as it is a common complication in many children I see with a variety of neurologic diseases. The combination of flaccid paralysis, underdeveloped limb growth, and decreased mobility may lead to osteoporosis, which can then increase the risk of fractures. Caregivers reported osteoporosis in 21% of children in Dr. Beauvais' study. Referral to endocrinology and monitoring bone mineral density with DEXA scans are very important. My work with AFM began in 2014 with 12 patients in Colorado, 4 of whom are pictured here. We, along with several other centers, published our outcomes at 1 year. In order to understand the long-term functional problems, it is important to understand the neurologic recovery in AFM. Distal muscles tend to recover earlier and better than proximal muscles. Profoundly affected muscles are least likely to recover. Several series have evaluated children at 1 year and show that 75 to 90% have some degree of residual weakness. Atrophy is often pronounced, as seen in these photos of children 6 to 18 months from onset. Recovery is most rapid in the first several months. However, ongoing functional improvements can be seen, and many children develop some amazing compensatory strategies, which we will see in a bit. On the first day of the symposium, we heard Rachel Scott describe the journey of her son, Braden, who who is continuing to make gains 4 years out with no signs of a plateau. The chronic functional problems I'll be discussing in children with AFM stem from the central residual muscle weakness, as seen in this schematic. Of course, none of these problems are mutually exclusive. A child with unilateral lower limb paresis can be at risk for femoral head subluxation, limb length discrepancy, and resultant scoliosis. And that same child can develop pain and fatigue related to his gait impairment. We need to continually monitor for all of these issues, as some may be less obvious than others. Just as with chronic medical problems in AFM, there is little data on long-term functional problems. Again, in looking at Dr. Beauvais' study, joint pain was reported in 29% and pain in the location of onset in 40% of children at a mean of 2.4 years after onset of AFM. Dr. Malacosta and colleagues reported on 31 children with AFM 6 months to 6.5 years post-onset treated at Kennedy Krieger Institute, 17 inpatient and 14 receiving only outpatient therapies. The patients at admission tended to report more neuropathic pain, which can be often treated successfully with gabapentin or Lyrica, while those at discharge reported pain in more of a muscular etiology. None of the outpatients reported pain in their study, so it appears that pain complaints can be just as varied as clinical presentations. 1/4 of children have been reported to have limb length discrepancies, so close monitoring of this is necessary with lower extremity x-rays and treatment with shoe lifts if minor, and referral to orthopedic surgery if more severe. Scoliosis can occur for many reasons. In a child with a leg length discrepancy, another child with severe shoulder girdle weakness and scapular asymmetry from upper limb paralysis, or from trunk weakness in children with quadripresis. Reports of scoliosis vary from 1/3 to 1/2 of children in these two studies. Monitoring with spine x-rays is important, and referral to orthopedic surgery as needed. Fatigue can be difficult to measure, but has been reported by caregivers in 50% of the 167 children in Dr. Beauvais' study. This merits attention and may warrant more subtle ways of measuring rather than by questioning alone. It is essential to ensure that children have appropriate equipment for mobility, such as a power wheelchair or power assist wheels if propelling a manual wheelchair causes fatigue. It is also important to continually evaluate orthotic needs, as those that are too bulky may cause excessive strain and contribute to the fatigue. But another that controls a foot drop, for example, could actually reduce the energy cost of walking. Contractures have been reported in 1/3 of children. These can occur due to the hypotonia or flaccid weakness, as well as muscle imbalance. Prevention, as well as treatment with positioning, passive splinting, dynamic orthoses, and stretching is essential. Surgical referral may be necessary in severe cases. Joint subluxation can be seen in the shoulder or hip due to severe proximal weakness. Shoulder subluxation can be difficult to treat, as taping is often not well tolerated, and slings are often rejected as they interfere with the intact distal limb and hand use. Hip subluxation can cause pelvic asymmetry and interfere with sitting and mobility. We will hear more about surgical management from experts in the field in the 5th session. In the next several slides, I'd like to share the stories of 2 of my patients with AFM. First, RH is a 7-year-old boy with a history of asthma who presented in October 2018 with a febrile respiratory illness and status asthmaticus. 4 days later, he developed flaccid left leg paralysis with muscle grades of 0 throughout. He also complained of back, hip, and thigh pain, for which he was started on gabapentin. He had no bowel or bladder or cranial nerve involvement. Listed here are his most recent strength measurements in his left lower limb at 20 months post-onset. And you can see now he has 1/5 strength in all muscles except recovered 2/5 strength in his gluteus medius and 3/5 or anti-gravity strength in his distal perineal and toe muscles. However, somewhat atypical as he has minimal dorsiflexion and plantar flexion. This is a video of RH walking at 20 months after onset in our Center for Gait and Movement Analysis. The Gait Lab can help us more objectively understand the complex gait patterns in children with AFM, as well as better monitor changes over time, especially as we have little knowledge as to how gait evolves in these children with skeletal growth and aging. As you can see, RH walks independently despite his profound weakness, and he uses multiple compensations to remain quite well balanced and upright without needing an assistive device or brace. You can also see the atrophy of his left lower limb, even through his shorts. Looking top to bottom, you can see that he lacks a reciprocal arm swing. He has a left compensated Trendelenburg pattern with left lateral trunk lean and trunk extension, both of which are compensations for his weak hip muscles, his hip abductors and extensors. Instead of left knee flexion at loading response, which is typical, his left knee quickly moves to end range knee extension. This allows him to have a stable limb in that extended position so he does not collapse. During swing phase, he uses left ankle eversion, those perineals, combined with circumduction to advance his limb and assist with toe clearance. Though he keeps his ankle plantar flexed at initial contact, he actually achieves a heel strike as a result of lengthening step length. These compensations will become more apparent in my next video. This is a screenshot of his EMG or muscle firing patterns during gait. Red is left and green is right. And you can see that the two sides look quite different. He has absent muscle activity in all muscles over the full gait cycle, except for the perineal muscles, firing at the end of stance phase, then out of phase activity during swing to help with toe clearance. In managing RH, I first wanted to note that he was initially prescribed a long leg HKAFO, or a hip, knee, ankle, foot orthoses by another physician, but he didn't use it very long as he found it way too heavy and bulky. He also used a walker for a short time after discharge. I decided to trial this toe-off carbon fiber AFO in clinic prior to his gait lab study, but as you can see, he was unable to take any steps as it took away all his fantastic compensatory strategies. Most importantly, his ability to extend his knee at weight acceptance. His gait lab data gave us some wonderful ideas for bracing, and it's clear that he needs control in both stance and swing phases. We'll be working on trials of different orthoses over the next month. He also has an appointment with Dr. Moore coming up. In terms of pain, he does complain of occasional left knee and back pain, likely due to his compensations. A neoprene knee sleeve has given him some comfort and a feeling of stability. Orthopedically, his last x-ray showed no hip subluxation, only a 5 millimeter leg length discrepancy, and a mild 10-degree scoliosis. We will need to continue to monitor these issues with x-rays. He has continued to receive ongoing physical therapy and electrical stimulation, and he works very hard. He does have difficulty running, but he still manages to keep up with his brothers. My next patient is CA, a 13-year-old boy who presented in August 2018 to an outside hospital with fever, headache, and neck stiffness. He was diagnosed with viral meningitis prior to AFM. 2 days later, he developed severe left upper limb weakness and neck pain. He also complained of dysphagia and constipation at admission, though these resolved in the first month. If you look at his left arm in this video, you can see the profound weakness with absent movement at his shoulder, trace or 1/5 strength in his elbow and forearm, and weak anti-gravity strength in his wrist and hand. He began an intensive occupational therapy program. His mother recalls him handling everything with a lot of positivity and resilience, but recalls him struggling and getting emotional a few times in the first few months. Once when he struggled buttoning his shirt for church, and another time when he was unable to catch his little sister from falling. Here are some images of CA at 3 and 4 months after onset. Notice the significant atrophy that has already developed in his left shoulder. Compared to his initial video, he is demonstrating nice improvements in his left arm strength after 4 months of therapy. At the time of this video, distal wrist and hand strength, as well as triceps, had returned to normal, and he was starting to regain anti-gravity strength and elbow flexion. You can see that he has clearly learned to compensate well for his deficits, as shown by how he climbs his hand up his body to get his arm overhead. In managing CA, he continued to receive aggressive outpatient occupational therapy. Kinesiotaping for shoulder stability was used early on until his proximal strength started to return, and he continued to use electrical stimulation 3 to 5 days a week. His neck and shoulder pain resolved, fortunately. Orthopedically, he had mild inferior shoulder subluxation that is now no longer evident. He has no evidence of scoliosis. He underwent a nerve transfer by Dr. Kozin 7 months post-onset with transfer of spinal accessory nerve to suprascapular nerve, median nerve to the brachialis, and ulnar nerve to the biceps. He has made a tremendous recovery, and he can now raise his arm overhead without using compensations. He still has mild shoulder and elbow flexion weakness, but continues to work hard and just completed 3 weeks of intensive strengthening with OT. Most importantly, he has been able to return to a sport he loves, cross country, which was very difficult for this ultra-competitive boy a year ago, as he had no left arm swing when walking or running. Little did I know how important this point would be before hearing Sarah Todd just give her speech and talk about dancing. But we need to remember the importance of getting kids back into activities they enjoy despite the extent of recovery, as we know there are multiple adaptations to make this possible. I want to thank my patients and families for teaching me so much about this disease. Management of AFM takes a team. These children are complex and no two are alike. We need to keep reaching high, learning and discovering in order to help children with AFM reach their full potential. And with that, I'd like to introduce Dr. Michelle Malacosta and Kofi Eno. Thank you.